Hello and welcome. My name is Cheyenne Beheshtian, and today I will be discussing with you aortic dissection, giving you a brief overview of it, some diagnosis, management, and a few clinical cases so that we can better help our patients when identifying aortic dissection. So first, I want to begin by talking a little bit about and reviewing about the anatomy of the aorta itself. The aorta arises, of course, from the left ventricle of the heart, and it sends a short distance, arches backwards to the left side over the root of the lungs and descends within the thorax on the left side of the vertebral column. And it passes through the aortic opening in the diaphragm and then it enters the abdominal cavity and terminates as the left and right iliac arteries, which are opposite the fourth lumbar vertebrae. Now, the focus of our talk for aortic dissection really revolves around the thoracic aorta today. So the thoracic aorta consists of an ascending aorta, the aortic arch, and a descending aorta. So I just want to briefly highlight the ascending aorta as two portions to it. The first portion is, or the lower portion of it is the aortic root, and that extends from the level of the aortic valves to the sinotubular junction. And that includes the annulus and the sinus of Valsalva. And then the second part of the ascending aorta extends from the sinotubular junction to the aortic arch. And so that's that. And then here in these images, again, you can appreciate better the three components of the thoracic aorta: ascending aorta, the arch, aortic arch, and a descending thoracic aorta. And then it terminates as the right and left iliac arteries. So now let's talk about dissection itself. This slide is to give you a brief take-home message of our talk today. But aortic dissection is defined as where there's a tear in the aortic intima. And what happens is that blood will enter and separate the intima and adventitia layers of the blood vessel apart and go into the media space. So it's going to push everything back, apart, and essentially will create a false lumen. A true lumen is where the blood vessel is where the blood flows, and then the false lumen is where the blood will enter, and that's not where blood should be, right? So because of that, there is a hematoma formation can occur, and the problem is because it's so high pressure, this blood, that hematoma will propagate and can cause the tear to descend deeper and deeper into the descend, for example, into the distal aspects of the aorta, the thoracic aorta. Key symptoms. When we hear a patient has very subtle, acute, strong pain, that's usually ripping or tearing in nature, this is a red flag that it could indicate dissection. And where the pain is matters. It could be if it's located in the anterior chest or the back. That's going to have a different clinical outcome, as we'll discuss. Key risk factors, one that I would take away from this discussion today would be that dissection really revolves around 70% of cases of patients who present with dissection have hypertension. So we do want to be aware of that. A little bit about epidemiology. Epidemiology, typically dissection presents in 60 to 80, so slightly older individuals. However, if it presents younger, in the 40s, the 30s, 30, 40, 50s, that could indicate underlying connective tissue disorders, Marfan syndrome, Ehlers-Danlos syndrome. But dissection typically is more common in males than females. Additionally, it's quite unfortunate that this is how it is, but most of the dissection occurs in the ascending aorta. As you can see, 65% of cases. This is unfortunate because this is, as we'll discuss, a Stanford type A classification, and this is a medical emergency. If left untreated, the patient unfortunately can die. The etiology, when we talk, the etiology that we talk about in acquired cases of dissection, big one, as I mentioned, hypertension. 70% of patients who have dissection have hypertension. So we got to keep that in mind because that can lead to wall weakening and propagation of the dissection. Trauma, it could be due to an accident. So there is a part of the aorta where after the aortic arch, where it's transitioning to the descending thoracic aorta, this part of the aorta is very vulnerable. It's not held firmly in place. So if a patient's in a motor vehicle accident, for example, that portion of the aorta can rip and can cause dissection. Another case of trauma could be when a surgeon's doing surgery and they're doing valvular repair surgery, and by mistake can cause dissection. Vasculitis, Takayasu arteritis, syphilis, these can cause. There was a case of syphilis that I will discuss, but this case is, it's really rare to see syphilis-induced aortic dissection. It's syphilitic aortitis. It's very rare, but it can occur. Drugs, anything that increases sympathetic tone, cocaine, amphetamines, pregnancy, usually third trimester or postpartum are at risk, and then arteriosclerosis. Congenital cases, these typically present in younger patients, so these would be connective tissue diseases, as I mentioned, bicuspid aortic valve diseases. So usually this is in Turner syndrome patients who have Turner syndrome, and then coarctation of the aorta. I have a case I will present to you about coarctation of the aorta causing dissection. And it's quite an interesting case because it was the cause of death was initially was made by the surgeon as a death because of the dissection, but post-mortem studies were done, and it was undiagnosed coarctation of the aorta that caused the dissection. Classification. So classification of aortic dissection, we have Stanford and DeBakey's classification. Stanford is the more typical one. This is the more commonly used, but historically we still keep DeBakey. So Stanford classification groups dissection by whether it's an ascending or descending aorta is involved. So type A, Stanford type A dissections involve the ascending aorta. It's anything proximal to brachiocephalic artery regardless of origin. So you can see here in this figure, right, in the figure here, it can extend proximally to the aortic valve and distally to the descending aorta. These are surgical and medical emergencies, right? So regurgitation and cardiac tamponade can result from this. So we do want to treat these patients immediately. Stanford type B involve the descending aorta and are not usually medical and do not require medical emergency, do not require surgical intervention for most cases. And these are involving anything distal to the left subclavian artery branching. Usually I'll talk about the medications that we can give these patients. Usually you start them on a beta blocker and then a vasodilator. Then we have the DeBakey classification. I've included this for just context. Type 1, typically this originate in the ascending aorta and continue to at least the aortic arch. Typically as far as the descending aorta. But again, these do require surgery. As you can see, they fall under Stanford type A. Type 2 also requires surgery. These involve and are usually restricted to the ascending aorta. And then type 3 involves the descending aorta and most often extend distally. Type 3 is subdivided into type 3A, type 3B. Type 3A is limited to the descending thoracic aorta just above the level of the diaphragm. Type 3B is below the diaphragm. So a little bit of a pathophysiology and clinical features. So as I mentioned at the beginning of this lecture, the vessel wall, right, there's a tear in the intimal layer. Blood will enter and create a false lumen in the media and forms that false lumen in the intima media space. And that can lead to hematoma formation, and that will propagate longitudinally downwards. This can lead to pressure rising in the aorta and resulting in rupture. So occlusion of the branching vessels can occur. Anything that's coming, if you have the false lumen, if you have, let's say that this is a true lumen, false lumen. Any typical branch from the aorta that the false lumen interferes with will cause ischemia, right? So you can see occlusion of branching vessels leading to ischemia. When I will discuss the CT scans, we'll see a case where the inferior mesenteric artery and left renal artery showed severe signs of ischemia. And that's because of the propagation of the dissection, those arteries split from the true lumen, and we're getting now basically barely any blood supply because the false lumen was feeding them blood, which is not that's a medical emergency. That's an example of a Stanford type B being a medical emergency. And then just a little bit of the molecular pathophysiology. The role of inflammation in cytokines. So there are various cytokines, GM-CSF, IL-6, and CXCL1. And as you can see in this figure here, there's a bunch of macrophages, lymphocytes, neutrophils in the area. And so they'll have the smooth muscles will undergo apoptosis. So you'll have by TNF and nitric oxide. You'll have extracellular matrix degradation by IL-6 TNF signaling for metallomatrix proteases to come in and proteinases come in and destroy everything, the ECM, and that weakens the aortic wall even more. And eventually it just leads to this vicious feedback cycle. Clinical features. So clinical features is very important that you understand it's a severe sudden tearing ripping pain. Anterior chest usually is involved with the ascending, back descending. Interscapular retrosternal pain, jaw and neck pain. If you have a jaw and neck pain, this typically involves the ascending aorta or specifically the arch. This would be signs of a medical emergency. Abdomen or umbilical, and the character, they can migrate. So sometime maybe in the morning they have like chest pain, and then because of the dissection propagating down the descending aorta, they can start to have back pain throughout the day. Hypertension can be observed as a result of dissection, or hypotension to those because of either shock or tamponade. Asymmetrical blood pressure is quite common, and pulse readings between the limbs being asymmetrical are quite common. There may be discrepancies in pulse and blood pressure. Occlusion of like a subclavian artery can result in a reduced peripheral pulse in the left arm, right? And so then the occlusion of the brachiocephalic trunk can result in reduced blood pressure to the right arm. So you can see those. So a widened pulse pressure, so systolic and diastolic pressure differences can increase. Syncope is a huge one. I think syncope is a really important clinical sign. The patient will collapse and then regain consciousness. Diaphoresis, excessive sweating, confusion, agitation, so neurological presentations. Chest X-ray, you'll see widened mediastinum. And if it extends into the aortic valve, then aortic regurg can occur. This is a really, really important point, and I really want to emphasize this. You'll hear a murmur of aortic regurgitation from the aortic valve. But typically, regurgitation, when you on auscultation for aortic regurgitation, you'll hear it on the left sternal border. For dissection, you'll actually hear it on the right sternal border. So this is quite interesting. Okay, so we will continue this lecture in the next video. Thank you.